Get started. Today I have the pleasure of introducing Dr. Dina Bainberg, who is an OB-GYN here with the Fond du Lac Regional Clinic. She graduated from Sackler School of Medicine, Tel Aviv University, and did her OB-GYN residency at Albert Einstein Medical Center. She's board certified through the American Board of OB-GYN and has been with us since June of 2019. And I also want to introduce Erin Simple, who is the clinical educator for OB. Erin graduated with BSN from Marian University and began working at Agnesian as an RN here in June of 2002 in women's and infants. In July of this year, she took her on a role as the OB clinical educator. She's certified as an International Board of Lactation Consultant Examiner and a member of the Breastfeeding Alliance of Northeast Wisconsin.
Can everybody hear me okay? Or should I use the microphone?
Yeah, microphone.
Can you hear me okay? Microphone? Okay.
Is the microphone working? Is this better? Okay, wonderful. So I'm just going to go through, I'm just going to get started with our objectives here. So our goal today, this was a project that our OBGYN department wanted to take on for a quality project to do some more education on lactation. So our objectives today are understanding the physiology of breastfeeding, describe the importance of coordinating a system-wide multidisciplinary training strategy, demonstrate the physician's role in supporting the breastfeeding dyad, and then effectively engage in collaborative approach to breastfeeding support. So we'll kind of go through all that today, and I will let Dr. Weaver take over here.
Hi, I'm Dina Bainberg. I just started back in April. Can you guys hear me? Yes? No? Okay. So this is just a brief overview of lactation. So lactogenesis starts pretty much during pregnancy and kind of ramps up in the third trimester to the point that some women will start to leak during third trimester. There's nothing wrong with still breastfeeding a prior child during pregnancy. It just might become a little bit more painful for them, but for the most part, they still produce milk if they were recently pregnant, and they do start making new colostrum for the upcoming baby pretty much toward the third trimester. The second stage happens at about day 3 postpartum, which is unfortunately by the time the moms come home. And that's usually when they have the most amount of problems. What happens is they get super engorged, very uncomfortable, they don't know what's normal, and they're already home. So that's kind of probably the time that some moms, especially if they're new, are going to have the problems of calling their physicians about what do I do, is this normal? And really it's just about talking to them, saying it's completely normal, try to continue to empty the breast, take some ibuprofen, drink a lot of water, it will really help. And that first 6 to 12 weeks is usually the most important in establishing supply. And after that, it's a supply and demand. So the only way to keep taking and making milk is if they continue to frequently empty the breast for the baby with a pump or the baby itself. The most important part of the breastfeeding aspect between the mom and the baby is that there's a good suckling reflex from the baby, because that's what the areola of the nipple respond to. What's really needed for lactation is the large drop in progesterone postpartum and the increase in prolactin. That's the hormonal aspect, and then the baby really needs to continue to empty. If the baby can't, people have pumps in the hospital as well as they can get it through their insurance. Biggest problems with establishing a supply is if they've ever had any sort of breast augmentation, usually more of a reduction, anything that affects the nerves in the areola likely will have a negative impact on breastfeeding, because there's no nerve stimulation sent to the brain that the baby's suckling. So that's usually why the breast reductions are more a problem than breast enlargement. Other issues being first-time baby, if they've had a C-section, usually there's a delay in skin-to-skin as well as initiating breastfeeding, so that's usually why there's a decrease. If there's a longer pushing stage, because it increases stress, any sort of medical benefit, diabetes, if they're obese, PCOS, if there's a retained placenta, they don't have that large drop in progesterone. Very rarely there's either just a structural abnormality with the breasts themselves. They never developed properly with establishing the milk supply. And then there's always pituitary issues, but those are usually very uncommon.
So our goal with multidisciplinary training, we actually have received a grant through the Ignatian Foundation to purchase the co-effective training. So we will be probably initiating that sometime next year after our EPIC go live, because there's a lot of changes going on right now. But what's really great about the co-effective training too, it's all staff members of the hospital. So the program is actually 18 hours of education for the nurses, so that will not just be the nurses on the Women and Infants unit, it will include the nurses in the peds and OB clinics as well. There's also 3 hours specifically for the OB/GYN and pediatricians. And these will be modules that will kind of be sent out through the MyLearning that we're currently using. What's really great with this training, there's also specific education for anesthesia, radiology, pharmacy, because they get a lot of questions about, I receive these medications, can I continue to breastfeed and things like that. But there's even training that goes along with this, again, for everybody. For food services, they will have some training on lactation and support. Our environmental services will get a little bit of training by purchasing this training through the co-effective group, which is really wonderful because, we all know that there's the goals, for Healthy People 2020 and increasing our exclusive breastfeeding rates. So this will help as a system that we're all kind of speaking the same language moving forward. We really want to use this program so we're all giving consistent, same information that's up to date when we're talking to patients about breastfeeding. We don't want to give any mixed messages. This training will also talk a lot about nipple shields and when that's appropriate to suggest that to patients, and when we feel like lactation services should maybe be involved in assessing the correct size of nipple shields. You can tell somebody, yeah, I think you'll need a nipple shield, but if they're using the incorrect size, we can actually cause a lot more damage than we are good for the baby for breastfeeding, because the pain can increase. You can actually get a lot more breakdown if the mom is using an incorrect size of nipple shield. We kind of want to, when we talk about speaking the same language and not mixed messages, I know a lot of times they say, oh, well, your milk isn't in yet. In working with women in lactation, sometimes they say, well, they told me my milk's not here yet, so what is my baby getting? So what I realized my language needed to switch as a nurse, that instead of saying, well, your milk isn't in yet, well, they have the colostrum and the body's producing it, so if we just kind of change our language and say, well, your mature milk isn't in yet, your body is transitioning. Because then the mom doesn't think like, well, I don't have anything, so I'm starving my baby. We don't want them to kind of have that mixed message as we're encouraging them to continue to breastfeed and work through those struggles. The second night syndrome is a big thing that happens in the hospital, usually that second night before they go home. We just really want to encourage moms that that's normal behavior for babies. They kind of take that first 24 hours after delivery to sort of rest and recuperate from the stress of delivery. They do about 6 to 8 feedings in that first 24 hours. Then after, beyond that, they'll do 8 to 12 feedings. So that baby may be wanting to eat every hour to 2 hours. And some moms think, well, the baby wants to eat all the time. Does that mean I'm not producing enough? Is the baby hungry all the time? No, what that means is the baby's transitioning, the baby's doing their job. They're doing like what Dr. Weber said, they're stimulating, they're pulling and tugging on that nipple, telling the brain to increase their milk supply. So just encouraging moms that second night, we're like, well, my baby was up all night, and all they wanted to do was nurse, they must not be getting anything. Just encouraging them that that's normal behavior for babies, and that's a good thing. That means that your milk is gonna come in and your body's gonna produce that. And we kind of wanna get away from saying, well, your baby's due to eat. So So it doesn't mean a baby has to eat every 2 hours, or the baby has to eat every 3 hours. They kind of have their own schedule. We really want to encourage and say, did your baby eat 8 to 12 times in that 24-hour period? Not your baby's due to eat, because sometimes people take that as, oh, well, did I do something wrong because I didn't feed my baby? The baby may have that 4 to 6 hour sleepy time that is pretty normal in a 24-hour period. They usually have one about 4 to 5 hour sleep pattern time in a 24-hour period, and it may have been during that time. Offering bottles. We've been teaching our nurses a lot to, instead of offering a bottle, maybe doing some cup feedings or syringe feedings. Drops to a teaspoon is actually considered enough milk in those first couple of days for a feeding. So a teaspoon's not a whole lot, about 5 mLs of breast milk is really great for a baby, and that's considered a feeding. And we really want to just make sure that we're giving all the same evidence-based information and advice to patients through this training and getting this training for everybody. And that we all know that babies do lose weight after delivery. Some weight loss is normal, and then when would be the appropriate time to refer them to lactation. It's really great. Our lactation program is growing. A lot of you may know Jody and Rita. They have been our 2 rockstar lactation consultants for probably the last about 20 years. But we're really building the program. There are 6 of us now here at St. Agnes, and we do some travel over to Waupun, so it's really great we're building that program to have that available for our patients.
So as physicians taking care of new moms, one of the first steps I think that's really important is that if you know your patient just recently had a baby, ask if she's breastfeeding, and if she is, if she's having any problems. The biggest concern is when women don't think they have the support. There's so many things out in the media, giving moms a hard time if they're not feeding their babies properly, or they're not giving them formula, or they're breastfeeding too much, or vice versa. So just kind of supporting them with any sort of questions, and making sure that we're not telling them not to breastfeed for certain medications, certain radiology studies, certain procedures. There's not very many things out there that would actually make a mom need to what's called pump and dump. And a lot of the times moms that don't make enough milk or just enough, if they have to dump that milk for the day, it's very stressful because they have nothing else. They literally just make to the very drop what the baby eats all day. So that could be very stressful. That can actually deteriorate the breastfeeding relationship. Any sort of latching issues or have to exclusively pump, that's always going to be a hindrance to continuing to breastfeed. Being attached to a pump instead of taking care of your baby is kind of difficult. So just supporting them, making sure there's a place that if they're running late to your appointment because they have to pump or because they need a pump or feed the baby, kind of be a little bit supportive and give them the space if they don't feel like doing it in public. I believe the hospital has at least 2 mothers' rooms, and I think there's 1 pump in each room. Okay. Each room has a pump?
No, they bring their own.
They bring their own pump, okay. So one of the main studies that I know a lot of breastfeeding moms or just new moms get, if we're ruling out PEs, the BQ study, that's really the only time you should really tell the moms to pump and dump for kind of a more common procedure. The isotope used, you have to wait a full 12 to 15 hours before the mom can actually feed the baby, so they can either pump and dump during that time, or if they have enough, they put the milk in the fridge and wait 10 half-lives, then they can actually feed that milk to the baby if they're under suppliers and they really don't want to throw it away. There are 2 apps out there. One is free, made by the CDC, called LactMed. It's an easy resource to just quickly look up the medications to see, hey, can I give this to a mom or can't I? It tells you all the studies and any effects on the breastfeeding relationship itself, like if it decreases milk supply. The biggest ones out there, probably especially with flu season and colds coming up, is any sort of antihistamines really can decrease milk supply. So if moms are uncomfortable, just let them know that, if you use it, just be careful, it might decrease your supply. Also steroids that are high dose, that can also decrease supply. The other app out there is called Infant Risk. It's made by Texas Tech. It's $10, and it actually combines what medications you can use during pregnancy, as well as the 3 different stages of breastfeeding. And this is a graphic made by the anesthesiologists in one of their publications about normal perioperative medications that are given for most procedures. As you can see, for the most part, almost everything used during the procedure, except for Demerol, you can actually proceed to breastfeed. You don't have to pump and dump. So the safest thing to say is, if you're awake enough to hold the baby safely, you can feed your baby. Actually, same thing goes for alcohol. A lot of the moms are told that even if you have a beer or a glass of wine, you have to pump and dump after. Typically, the breast milk has a lot less blood alcohol content than what you're drinking from, like the wine, beer, or whatever drink you're having. So let's say if you're very intoxicated and your blood alcohol level is like 0.1. Well, that's what the breast milk has. So if women are uncomfortable giving any sort of alcohol, they can kind of wait until they sober up a little bit, but if they are safe enough to hold the baby, typically they can feed the baby. As far as I know, orange juice sometimes can have more alcohol content than natural glass of wine or not. Little things like that I think can continue so that they don't think they have to stop the relationship just for certain amounts and certain activities that they're doing. Some beers can actually increase your supply, so
So as we move forward with collaboration, so we've worked really hard with the physicians, the obstetricians, the pediatricians, and the staff up in the Women and Infants Unit about, we've implemented some changes in practice in the last couple of years, which have been really great to support breastfeeding. We do skin to skin right after delivery in the labor rooms, and we're also doing it in the OR. We do in the OR that initial stabilization. It takes about 5 minutes, and then the baby goes right to skin in the OR while the mom is finishing her procedure. Sometimes even those babies in the operating room while they're finishing the procedure will start suckling and nursing while mom is spending that time with her baby while the physician is finishing up. We've changed practices in the last couple of years where we used to give formula for low blood sugars, for low glucose for babies. We are using glucose gel now, which is really great. Instead of introducing formula in a bottle, we're giving them some glucose gel by rubbing that on the inside of their cheeks to help with those babies that have hypoglycemic issues. And then feeding them right away with breast milk to help those blood sugars. So we've also, there's been a lot of research out there about delaying bathing. We've delayed bathing of our babies for 24 hours after birth. It's been shown that they stabilize their temperatures better, they learn to stabilize their own sugars better by delaying the stress of that first bath. Moving forward, some changes that we are working on moving forward. We want our babies to not be interrupted with feedings for procedures, allow them to finish. In those first couple of days, the baby's learning. And with their neurological system, they're kind of, when they get to the breast, they sort of have to kind of put all their ducks in a row to latch on and be able to feed. So once the baby's latched on, 5 minutes later, we don't want to take them away from the breast. We want them to allow it to finish that feeding before we interrupt that. We would, allowing breastfeeding prior to circumcisions because breast milk is a natural fluid versus formula. As we move forward, we want to continue to have that team approach with the physicians and with the staff and our lactation consultants to increase our breastfeeding rates. Not just increase the breastfeeding rates, but what's really important, what we want to increase is that exclusivity of the breastfeeding, that we're not introducing artificial milk. So we want to definitely decrease our supplementation of our formula. We are in the process. We also did get a grant from the foundation. We are in the process of setting up a donor milk program where we will be receiving pasteurized human donor milk from the milk bank, the Great Lakes, something that it's a really long milk bank. And we will be receiving that. So we're in the process of making consents and making protocols and things like that and going through all those channels. Along with that, we are having a depot program here as well. So for those mothers that maybe overproduce, and when they're done breastfeeding, they have a lot of frozen milk left over, and they're like, well, what do I do with all this? We will actually be a depot where those mothers can make an appointment and drop off their frozen milk. And we will send that into the milk bank for pasteurization. If you have any patients that would maybe be interested in that, please have them contact one of the lactation consultants as we get this program up and running. It's really great. They can use that milk for babies in the NICU and different things like that. It's a really great program that they have. We also are setting up a more systematized outpatient program. We've always seen patients as outpatients. To help with appointments, we will, now most insurance companies will allow us to actually charge for outpatient visits for them to come and see a lactation consultant. So we're in the process of getting that set up and working with that as a lactation group and with leadership. If you have a patient that you feel like needs to see lactation as an outpatient, the number that you would call, the extension is 4837. I'm sure some of you have called it before. A lot of times if we're not in the office, we're out seeing patients. The office is currently located on the first floor, kind of back in by where Journeys is, behind the little cafe upstairs on the first floor. We have office and exam room where we can see moms. Hopefully by the end of the year, there will be some construction and they will actually be moving up to the 6th floor where women and infants is, so that we will all be in one spot. If you are calling us and leaving us a message because you have a patient that might need to be seen, generally we get back to that patient usually same day or the next morning. It would be great if you could leave us the mom's name, the baby's name and date of birth, because it helps us know, like, when I call this mom, is her baby 5 days old, or is this a 6-month-old and mom has a question? What the issue or problem is, and then the best phone number to reach the mom back at, so we can call them, talk to them, sort of see what the problem is. If it's questions we can answer over the phone, we will, but if we feel like they need to come in and be seen as an outpatient, we will set up that appointment with them. So as a group for lactation, kind of made like a referral list. So things that we thought that would be appropriate for you to refer back to us so we can really counsel these moms and again kind of protect that dyad as we move forward. Any primip or first time breastfeeding mom. So maybe her last baby she formula fed, but this baby she decided to breastfeed. It's her first time actually breastfeeding. Any multip that struggled with breastfeeding in the past. If she had issues with supply in the past, we want to see her as soon as possible so we can kind of get on that right away. Any baby, for those of you that do see newborns in the clinic, any baby that doesn't have yellow stools by day 5, that's exclusively breastfed. They should have those transition stools by day 5 into that sort of yellow CD stool. Or any baby that's not having a stool every day during the newborn period. They really should. That breast milk is kind of, and colostrum is kind of a natural laxative, so they should be moving all that through. Any weight gain issue at any time, the earlier the better. So if you're concerned that the baby lost 10%, we'd rather see them versus when the baby's now down to 15%. We would like to kind of get on that as soon as we can to effectively increase that milk supply and get baby eating more and gaining. If you think a baby needs any supplementation or fortification, whether we can maybe supplement, maybe baby gets tired at breast because it's a premature baby or a small baby, can we supplement maybe with express breast milk versus formula? Is mom actually producing enough where maybe she nurses for 15 minutes, but she makes enough milk where then she can pump and get another ounce of express breast milk? Or if you're feeling like you need to supplement with formula, we would like to see her because we would like to give her some resources that would maybe help her increase her milk supply. So if her goal is to exclusively breastfeed, maybe we could taper off the formula and go back to just exclusive breast milk. Anybody with sore nipples or sore breasts, we would definitely like to see them because That's a latch issue. We want to correct that, because if we don't correct that, the baby's not going to transfer milk very well, and then they won't gain their weight, and they're kind of expending more calories than they're taking in. Low milk supply, definitely. If they had a breast reduction, we'd like to check that, kind of where the scars are and everything, and see if that will affect their ability to make milk and their ability to feed their baby. Anybody that has delayed lactogenesis, and I know Dr. Bainberg kind of went over those different things that can kind of delay that at the beginning of the presentation, we would definitely like to see those moms we like to talk to moms before they go back to work. A lot of them have questions on when should I pump? How often should I pump when I go back to work? I'm not really sure. I've been home for 6 to 12 weeks. And I know a lot of, we see them at, 6 weeks postpartum, or you may be seeing for another, and they're like, oh, I'm kind of nervous about going back to work, and I'm not really sure how that's going to work with feeding my baby. And is there a place for me to pump at work? And we can kind of help them work through that and give them ideas on how to make sure that their milk supply doesn't drop when they go back to work, because a lot of moms that does happen, because they're most relaxed and they're most comfortable when they're feeding their baby. And when they go back to work, they're away from their baby and the stress of that. And not having their baby next to them while they're in just pumping, it can decrease their supply. Any baby has hyperbilirubinemia. Latch issues. Anybody that you think needs to use a shield, we talked a little bit about that. We want to make sure that they're using the correct size, because we don't want to cause any damage. We will see moms or babies that are thinking maybe they have thrush, mastitis, or an abscess. We'd be happy to see them in the clinic. If they have repeated plugged milk ducts, like if it kind of, you get rid of one plug duct and another one comes up and it's kind of this repetitive thing, we want to sit down and have conversations with them and figure out what's going on and why that's happening and how we can resolve that. Any babies who's hospitalized or has been hospitalized, if a baby went home, was doing fine, maybe is coming back into the hospital for various reasons. I know we have cold and flu season coming up and RSV, and if any babies are admitted and these babies maybe are breastfeeding and not maybe eating as much because they don't feel well, we'd be happy to see that mom. If the baby's admitted into pediatrics, just to help them work through that, to keep their milk supply up through that time. Any mom who has trouble maintaining supply for an infant to toddler, we have people that call at 18 months and ask us questions. We'd be happy to answer those, not just about newborns. Establishing supply or older babies starting solids, how do you transition that? There are some people that have high anxiety about breastfeeding. We'd be happy to sit down with them and talk to them about that. Tandem nursing for those moms that maybe had a baby and are continuing to breastfeed that baby, and now they have a newborn, and that tandem nursing, you can do that, and your body will make enough milk for both. We can help them work through that if they have a young child that's maybe not transitioned off of breast milk. We can help them work through that tandem nursing. Any nursing strikes, there are some babies at certain times just kind of, I'm on strike and I'm not going to eat and you can't make me, and mom's kind of pulling her hair out. We would love to sit down and talk with her. Growth spurts, a lot of moms kind of are at home going, oh my gosh, everything was going so well, then the baby hits a growth spurt, the baby is just ravenous and wants to eat all the time. The 10 days, the 3 weeks, the 6 weeks, kind of those growth spurt times, we'd be happy to talk to moms about that as well. How to wean appropriately. We definitely want women, when they decide to transition out of breastfeeding and weaning baby, we don't just want them to quit cold turkey. There can be some problems that arise just from just stopping breastfeeding, where you could possibly get plug ducts and mastitis and things like that. Any sucking problems. Any medical conditions of the mom that we talked about, that Dr. Weber talked about earlier, that can delay lactogenesis. Definitely any preemies. Those babies, we want to make sure are getting the calories they need and not expounding too many calories, that they're taking in what they need. And then any special needs babies, definitely. Those babies that kind of have low tone, sometimes it's hard for them to create the suction at the breast. We would definitely love to sit down and have an appointment and talk to them. What was requested when we did this, that we would kind of have a question-answer time. So I have 3 of my partners here for lactation. So the lactation consultant, Dr. Vainberg, here. So I have Desiree Frank here, Rita Parker, and Jody DeMau back there, also lactation consultants. So we'd really just like to hear from you guys and answer the questions that you have. Does anybody have any questions?
Y'all had advice for mom. So yesterday, a working mom was concerned about going back to work here shortly. And are there workplace laws that give moms time and place for pumping at work?
Yes, there are. I believe it's any company that has, is it 50? 50 or more employees has to give the mom a place to pump that has a sink and that's clean for her to store her milk.
It can't be a bathroom, and
They can't be like, go out to your car and pump.
Right.
And if the company has less than 50 employees, that would be something we could definitely sit down and talk with her about. I have talked with people like, well, I work for a company that only has, it's, a family company that has 10 employees. Okay, I've sat down and talked with them like, well, why don't you talk to your manager, here are some maybe suggestions, and talk to them about how to present this to get you the time that you need down the road. But the laws do say any company that has 50 employees or more has to provide the time that's required by law. They don't have to pay them for the pumping, but they have to allow them the time to pump.
I think it's a federal law, so it's across.
Well, I told her about the word, but I wasn't sure. I said she works at Quad Graphics, so well, it's a big enough company that they're human
Yes.
resources can tell you.
Yes, so they do have pumping rooms out at Quad. I do know that, and I know they have some at Grande Cheese for sure, and I believe Mercury in town has pumping rooms as well. Kind of some of those bigger companies in town do have pumping rooms.
Some states have like specific protective laws that pretty much across America you're allowed to actually breastfeed in public wherever, you have to have it covered. There's some states that are specific to say, like more protective instead of just saying you're allowed to without having it covered, but some states are a little bit more protective of the mom saying if you are accounted that you can't be asked.
What other questions do you guys have for us?
Talk about costs, is it complimentary or billed through insurance?
So for the outpatient visits?
Yeah.
So how the program is going to be set up is most insurances, it sounds like in the research we've done, will cover 5 outpatient visits for mom. However, we've always not kind of charged for them. It's kind of just been under community benefit. So the decision was made that we will submit it to the insurance company and we will take what the insurance company gives us, but the remainder we will not send mom a bill. That will be covered under community benefit. So we will take, if the insurance company kind of gives us a batch charge, we will take that, and then the rest will be considered community benefit like it was in the past. So there will be no charges going out to the moms for baby outpatient visits or mom outpatient visits, because depending on what the issue is, the baby registered, the mom may be registered as the outpatient or the baby registered as the outpatient. Oh, we do also, Rita reminded me, we do have a support group that meets twice a month. It's the second Wednesday of the month during the day, and is it the fourth Wednesday in the evening. So if you have any patients want to kind of get out of the house, meet other moms, it's a really great way. The women get together. They kind of talk about the problems they have, and they sort of answer their own questions. It's kind of really neat. When I've sat in on support group, I just kind of sit back and they kind of all talk to each other, and they kind of answer each other's questions, and it's a really great way for moms to get connected with other moms in the community. And then a lot of them too, we do weigh all the babies that do come, no matter what age they are, and let them know how the baby's going. So Support groups are a great way for moms to get connected. Are there any other questions? Yes, sir.
How do you approach moms that say they don't want to breastfeed, breastfeed, but do you try to persuade them?
No, our goal is to not persuade them. My goal would be to just say, well, do you have any questions about breastfeeding? Or, maybe ask like, well, what would be your reason for not breastfeeding? And then, maybe, there are some cultures out there that say, oh, well, colostrum's bad. It's not good to feed my baby colostrum. I would give them the information, but ultimately it's their choice. They're the patient. They don't have to breastfeed. But the moms that do choose to breastfeed, our goal is to protect that diet as much as possible as a group.
What percent of mothers breastfeed these days?
I think our last couple of months percentage of breastfeeding rates is like 78, 82 is exclusive breastfeeding. Somewhere like high 70s, low 80s is our exclusive breastfeeding rate. I think Healthy People 2020, I think the goal is supposed to be, is it 85 or 83%? So we're just under the goal for Healthy People 2020 for exclusive rates. We kind of bounce between about 78 to 82%. So we kind of want to really ramp up and increase that exclusivity.
I think like 6 months, like the data, the 40% of women are still breastfeeding at the 6-month mark and even less at the year. And a lot of people think it has to do with return to work, but if you look at the rates of breastfeeding in Europe where they have like 1 or 2 years of maternity leave, their rates are not that much better. So that's part of the problem with return to work.
Any other questions that we can answer for you? Well, thank you for allowing us to come and speak.